Cool. Well, hi, everybody. Thanks for joining us here, what we called Freedom DPC and me. So what we wanted to do is continue this. Every couple of weeks. We have kind of what we call an expert panel of physicians who are doing DPC, either just started out or very experienced in DPC. And so what we wanted to do is get people together so they can share their experiences with people who are interested in DPC or have learned enough about the DPC model where it really speaks to them. So today we wanted to take a focus on some physicians who were what we call early career physicians who are doing DPC. Dr. Jake Dewitt is joining us here from Westfield Premier Physicians. He recently joined that practice. And so he's a fascinating story, more rooted in a business career, and then found his calling in medicine once again. And then Dr. Edward Williams, who's down in Alabama, is just going through what we call our startup process here at Freedom Healthworks. So just getting his groundwork and his foundation laid for his practice, no pun intended, but his practice is actually called Foundation DPC in the Mobile Bay area. So hopefully he's able to join us and tell us a little bit about what his experiences were with his career and why he was motivated to go into DPC, and then what it's really like working with Freedom Healthworks, because I know that's the big burning question. So we ask everybody always be very honest, and you know, we think we do it pretty well and some of the best in the industry here, but you know, there are other things that we're always improving. So be sure to ask a lot of questions. The way that these Zoom webinars work, there is a Q&A button, down at the bottom. And so you can click that and then you can type your questions. I will get that as your kind of moderator today. And then we'll have a Q&A session here at the end, you know, for hopefully both of our doctors as they're able to log into the webinar here. We are recording everything, so if there's anything that you wanted to go back and review or that you feel like you missed, not a problem. We can send you the link and you know, hopefully answer any questions as they come along. So with that, I'll introduce Dr. Jake Dewitt and let him take over and kind of give him some background, let him give a background about himself there and, you know, what kind of led him to medicine in the first place.
Yeah, thanks, Chris. Hi, everybody. I'm Dr. Dewitt. Just call me Jake. My background, as Chris had alluded to, is a little bit non-traditional. I had a former life in business. I helped start a federal contracting firm back in 2007, and then an independent consultancy after that. I was prior to entering the field of medicine. My decision, though, to enter medicine, it was driven by a desire to help and heal others. It was fueled in large part by my father falling ill before we lost him. And I'm very happy with the decision to come into medicine. But I recognized early on in my medical studies that I wasn't overly thrilled with the way that medical education and graduate medical education are structured. I did my undergraduate studies at the Purdue School of Science. I went to medical school at Indiana University School of Medicine. And then, Chris, did you want me to go ahead and talk a little about kind of why I chose DPC and my path to you guys, or just kind of save that for later?
Yeah, we actually just got Dr. Williams here joining us, so hopefully he is able to log in and get the video up and going. So great timing there, Dr. Williams.
Y'all hear me at least? Okay, there we go.
There we go.
Yeah.
Hey, welcome. Glad you can make it.
Yeah. Susan told me not to forget the call, and I almost sent back what call. My bad. Okay, can you repeat the question? I heard a little bit of what Dr. Jake was talking about. But
yeah, so we just got started here, and Dr. was just giving us some background on kind of his history in medicine, his career up until this point, and then we'll get more into the motivations of why you chose to go into DPC.
Oh, okay. Yeah. I started off, got out of residency about a year and a half ago, signed on with a hospital system. They kind of just put me out in an outpatient clinic without really any help, essentially. They were like, all right, here you go, bye. And I was like, okay, well, I'm a doctor, so I can do a bunch of stuff. And every time I'd ask for help or kind of assistance or try to manipulate a policy that would better better care for my patients, they would always come back at me and remind me how it wasn't my clinic, it was theirs. And as soon as that started happening, I was like, well, there's got to be a better way. So I started researching direct primary care, and eventually found some podcasts that Mr. Habig was doing, and I liked what he had to say, and started researching it, and eventually came to the conclusion that this path that I was on, and technically am still on, I guess, until November, but there had to be a better way, and we'll be proceeding with starting my own clinic in January. So super excited about it.
I'm gonna go back to Dr. Dewitt. Yeah, go ahead. Give us your rundown of why you found DPC, or if DPC found you, vice versa, or if you listen to some entertaining and educational podcasts like Dr. Williams down there.
Never miss an opportunity for a plug, right? Yeah, so DPC, yeah, I guess you could say that DPC and I kind of found each other. It's a lovely marriage, although it's still in its infancy. So I had initially been on a pretty academic track. I considered pursuing fellowship. I'd matched into obstetrics and gynecology at one of the two programs here in Indiana. I presented research and got published and totally thought that's what I was going to do. But I found during residency that what the most rewarding facet of medicine for me personally involved direct patient interaction, preventative health, and continuity of care. And I didn't want to give those things up. And what I have found, my time, my short stint so far in DPC, is advantageous across the board, really. It's just a breath of fresh air, especially coming from really large institutions like I did. The restrictions that are imposed in major healthcare systems are not a factor in DPC. Calibrate your work-life balance to your liking, sort of titrate to the precise number of patients that you desire on your panel. Get much, much more time with each of those patients. You can offer them, in my mind, superior care, service, and value. And I think that because of that, the providers that are in DPC networks, they feel less like a number, and the patients feel less like a number too.
Dr. Williams, you mentioned something there about the hospital system coming in and saying, no, these aren't your patients. Was that one of the motivating factors into going out and saying, I want to take care of people my way?
Yeah, I'd say that got it started because when you first get out of residency, you're so amped up to do anything you can for anybody that you come across, especially in primary care. It's just a super slap in the face when somebody says that's not how you're going to do things, and especially when it comes from I guess essentially your boss. Don't like to think of it that way, but and that was like the first one, and then COVID hits and you're trying to make split-second decisions about keeping your patients safe, and the suits in the hospital system that's against policy, and I'm like, well, the policy is going to get somebody hurt. I didn't sign up for getting people hurt. I'm going to do the best I can for my patients, and it just creates this abrasion that's not necessarily needed. But yeah, those things stack up, and eventually you're like, this is not what I signed up for. I signed up for my patients, not some suit telling me how to practice medicine, where, sorry, I'm getting a little amped up, but like I want to answer to my patients. I want them to be the boss instead of somebody else. I want to work for them and not anybody else. So this system that I'm moving into, DPC, allows just that. So and I think it's brilliant. But yeah, the first kind of domino was them coming out and going, this isn't your clinic, this is ours. And I was like, okay, that's how it's going to be, huh? So I kind of rambled. I hope that answered something.
Yeah, and we're trying to just give everybody kind of a wide breadth of what your experiences are, because again, we wanted to establish this for any physician who is very early in their career and might be coming out of residency, experiencing the employed healthcare system, and then saying, hey, this isn't for me. So what were your experiences looking at DPC, researching DPC, and then ultimately deciding to launch your DPC practice in the midst of a pandemic?
Yeah, so for the residents out there, I don't know about y'all, but I never got any type of lecture on finances, running your own business, or anything like that. And I didn't take anything in undergrad as far as business classes went. So whole new world out there when you, graduate. Yeah, I mean, what got me looking into DPC was like just going home, driving home every day going, there's got to be a different way to do this. This is not correct. And if you Google search like, other methods to practice primary care, eventually you're going to go down a rabbit hole that you're going to read an article about DPC, and just the first thing it says will grab your attention and go, yeah, that's exactly what it should be. The oldest school of medicine needs to be kind of reborn, essentially. Just patient and doctor. That's it. Residents, y'all have made it to the end of residency. You're taking board exams. You are smart, and you are the best that there is if you get past residency. So don't let anybody tell you how to practice medicine. That is not in the best interest of a patient. So if you're still a resident, then you don't have these nightmare scenarios just yet. But if you get into fee for service, it'll happen. And if you're already thinking about DPC, there's just going to be this bug in your head going, every little thing you see, like let's say COVID hits and your patients, drop from 20 a day to 2 a day. You're going, maybe there's a way to, keep my doors open that didn't require this. Oh yeah, DPC allows that. Getting patients back in for like lab results that are negative or just so easy to pick up the phone and go, hey, you're good. Okay, thanks, doc. Like that's a way better option than having somebody come into a clinic that could potentially sit in a waiting room and get sick or something like that. Just stuff like that. I mean, the stories are just endless. So yeah, if you're already thinking about DPC, I guarantee you're not going to go into fee for service and go, yeah, this is better. So just, those are my thoughts.
Chris, if I may piggyback on what Dr. Williams said.
Yeah, absolutely.
Big things there. First, with respect to, not having a lot of exposure during residency to business, I interviewed at 13 or 14 programs for residency, and I think only one of them offered at any point in the curriculum a course on business of medicine. And that's actually what that rotation was called, business of medicine, but it was like 1 month out of 4 years. And I think some of that, and this may sound a little cynical, but I think some of that's very intentional. I think a lot of large residency programs that are affiliated with academic institutions and big systems, they anticipate to retain some of their own residents and to have them sign these restricted non-competes fresh out of residency. They dangle a carrot, people get locked into this stuff, and then they don't really have the option for some time to come to do a DPC. And other healthcare systems don't want their up and coming docs thinking that there's a better, a more elegant way, a simpler way of doing this that takes money out of their coffers. But with respect to the COVID point too, my practice that I joined is a perfect example of that. Throughout all of COVID, the doors here were never closed, not once. Now, all the precautions were being observed. We've been very, very careful and strict about masks and limiting contact and distancing people. And so we're not shirking any of the guidelines. Our primary objective is to keep our patients safe and healthy, obviously. But just because of the nature of how we're built, how our practice is designed, we were able to see people, whether it was telehealth, over the phone. Big part of the DPC model, depending on how you want to build your practice, is you can offer your patients 24/7 physician access. You can offer your patients unlimited appointments over the phone, in person, however they want to do it. And so I think this pandemic, in a lot of ways, has illustrated, at least in this practice, one of the many advantages to doing it this way.
Yeah, and that's a really good point. That again, kind of going back to Dr. Williams there, you mentioned that you can make it your way. Dr. Dewitt, wanted to ask you, give everybody kind of an overview of what your patient acquisition strategy is and how you've been involved really with the local economy and local businesses and doing a lot of outreach that way.
Yeah, absolutely. Well, the first thing that I would say, my short life, I have been fortunate enough to meet a few thought leaders, and Chris is absolutely one of them. He's kind of a kindred spirit. And so, from a Freedom Healthworks perspective, I can tell the people listening to this, there's a huge difference between enlisting the help of an accelerator, or a proven accelerator, versus trying to do this on your own, because the advice that you're going to get, the package and support infrastructure you get is a big part of that success. And it enables you to then devote more of your time to networking, because that's in large part how this gets built. And so some of it's, word of mouth, some of it's people, they Google search, a new practice because their disgruntled physician is retiring, or the patient themselves is disgruntled because they're tired of waiting weeks and weeks to get in for a 15-minute appointment, which is often preceded by a lengthy stay in the waiting room and then truncated because the physician is rushed to see 30+ patients a day. And so I've seen, patients come from both sides. Hey, my doc's leaving, I need someone new. And also, hey, I'm just, I like my doctor personally, but I just don't like the way that office is run. And then it's kind of a family capture. I mean, a lot of these patients who've signed up looking for a new doc, they have children, they have spouse, they have, siblings or cousins who are looking for somebody new. Chris with Freedom, is kind of a crack wizard in terms of trying to help people infiltrate the local networks in a way that's healthy and constructive. So the practice that I joined, they put out their own release to their existing patients, but we also did a local Chamber of Commerce press release, and I think that that's hugely beneficial. I think relying on some of the social media platforms, Nextdoor, for example, is a great way of getting some information out. And I think really just not being afraid to talk to other people. I've picked up patients now from a massage envy. I've picked up patients from a restaurant, a waitress that brought a to-go order to my car. And so just having conversations with people, because this type of model allows you to do that. They don't have this intricate labyrinth that they have to progress through to get to you and to get to your practice. They're not going in through an administrator or a queue of receptionists. You can have those one-on-one conversations, and that can develop into a one-on-one patient-doctor relationship.
And Dr. Williams, you are in the process of establishing your DPC practice, so you're still, technically an employee of your system there. What have your experiences like deciding to leave your employment and start up a business at the same time?
Yeah. So anybody that's been through this process knows just how big that decision actually is. It's not exactly like, hey, I'm moving. It is a massive decision, because with employment you get your malpractice, your benefits through some employer, and making the decision is not a light decision, but kind of knowing in my heart of hearts that going down this path would not lead to anything good, and knowing that there's something better out there, you kind of have to stand up for yourself and, look yourself in the mirror and go, yeah, it's going to be scary, but freedom, especially freedom, will help you navigate the world that we are not trained in, which is getting all your insurances together, exactly where to go, like who to call, and kind of hold your hand through the process. And I still do need my hand held, for sure. But it just gets to the point where you know you're built for something that is a little bit different, and you just have to have the, standing on the edge of the pool, man, you just have to jump in. You got to do it. But definitely not a light decision. So really think about it if it's in the best interest of you and your family. But I think it is, so I made that decision. And let's do this. I'm in. So,
what was it like, Dr. Williams, putting your notice in? What was your reaction from the employer? Because I think a lot of people are fearful of pushback or lawsuits, anything along those lines.
Yeah. So, you got to stay detached. You got to stay professional. As much as I wanted to kick in the door and like throw them the, notice, you just have to relax, take a deep breath, and just say, hey, don't give them any details that would be overbearing. I just kept it simple. Hey, thank you for the opportunity for letting me work here for a year. I'm going to be doing something else. If you have any questions or would like a exit interview, please let me know. But here's my 90-day notice. My last day will be November 30th in my case. And just gave them that piece of paper. I sent it to, I gave it to them. I sent an email to have that timestamp, and, just kept it simple, kept it professional. You don't want to burn any bridges or hurt anybody's feelings. But yeah, I mean, it's your personal decision. And if they don't respect that, then that will reinforce that you made a good call. So, just keep it simple, keep it professional. Don't burn any bridges. Don't make a scene. And just stay, as professional as possible. That's what my advice would be.
Yeah. Dr. Dewitt, question for you. Since you are joining a DPC practice, but in private conversation, you told me that you were ready to stand up your own independent DPC practice right after getting your license. What were some of the factors that we might not have covered that made you do that? Because we usually don't see that a lot in DPC, that somebody comes out of residency, gets officially licensed, and then immediately goes into private practice. Usually someone takes what we call the gap year. Dr. Williams just alluded to that. So what were some of those factors in making that decision before you found a local DPC that was wanting to bring you on?
Yeah, well, I appreciate the question, and I recognize my background's a little different than a lot of docs, and so I think that in some ways that led to the decision because I was perhaps maybe a little less trepidatious. I guess having started a couple of companies in the past, but to be honest, again without using any names or anything, I was very close with a lot of residents who were becoming jaded early on in residency. And I'm very close with several of my former attendings and fellows and people in my academic network who, on more than one occasion, had told me, had kind of hinted indirectly or just said it outright that they wish they had gone a different way, or they just would lament to me the days gone by, but sort of the way that they thought it could never be again. And initially, as a learner, you hear things like that, and you just think, oh, it's like listening to an uncle or a grandparent, that this is the way things used to be. But I think if you're paying attention, I applaud Dr. Williams for what he's doing, and I applaud you, Chris, for helping people get to this option. If you really pay attention, even in medical school, even as a learner, you can start to pick up on some of the nuances that are pretty toxic for patients and for physicians. There's a reason that physician burnout is at an all-time high. That's not just an outlier in the data. It's been a trend, and it's because doctors are being forced to see more and more patients per day. They're not satisfied. The patients aren't satisfied, and I've come to appreciate that DPC in many ways has been born out of necessity, as a rejection of the direction clinical healthcare has been moving for the past several years in an era of large buyouts. As Dr. Williams had mentioned, he had this experience with his employer, which is unfortunate because it undervalued him as a physician. and as someone that wanted to care for his patients. Primary care within major institutions, it imposes restrictive non-compete clauses. They control how you refer, to whom you can refer, how many patients you're supposed to see per day, how those patients get billed, who can see which patient, et cetera. And I think that this model of care that you help physicians achieve, it empowers the physician, preserves the provider's autonomy, and it's more satisfying for the patients. I mean, just the time that I've had here has been much more fulfilling and enjoyable, than any other way that I've ever seen medicine practice.
Question here for both of you. Dr. Williams, I'll let you go first here. What are those conversations like with your current patients, given your current situation? What are those conversations like? Because again, if people want to start their DPC, it's important to do a lot of pre-sales without violating any contractual terms.
Yeah, so the conversations with my patients currently are going quite well. It's not that they are against the idea, it's that they didn't know the idea existed. So they'll always come in, hey, I heard a rumor that you're leaving. And I always go, I'm not leaving anybody. I'm just relocating and starting my own thing. And once I explain what it is, they're like, well, that is just brilliant, because I'm just sick and tired of, not being able to talk to a provider if I need to ask them a question or something like that. I'm like, well, what I'm doing now is, taking over the ship, and I want you to be my boss. I always throw it back at them. Hey, I don't want to work for them. I want to work for you. And they're like, oh yeah, that makes me feel a lot better. And then I explain what will be happening. And I have not met one person that has gone, well, that's a dumb idea. No, I've not had that happen. They always go, well, that sounds amazing. And they either, wish me luck, or they're like, well, I'm coming with you. And I'm like, okay, that's cool. But really just great conversations. But the thing is just explaining to them what it is, the knowledge of what DPC and what we'll be doing is just not there. So once you explain it to them and give them the elevator pitch, their eyes light up and they're like, yes, that's all I want. So good things. I mean, I haven't had a bad one yet, so excited about it too.
Yeah, Dr. Dewitt, going over your way now, you're mentioning that you're picking up new patient enlistments just from spreading the word, talking to people, giving you the carry out at restaurants. What are those conversations like? What's working? What are people's responses to that?
Yeah, so generally it's just a lot of it starts with just a very human conversation. Just talk to people about your day and your background and that kind of thing. And as Dr. Williams had alluded to, a lot of these patients, when they hear about this model, a lot of them, I mean, their ears really perk up because this is such a foreign concept to them. And I think it's a foreign concept to a ton of providers out there too. So I've talked to resident friends and ex, co-residents and people I went to med school with. And I would say most of them did not even know that this was a thing. And so when I talked to, this waitress, for example, it was something kind of silly, like anything can trigger an elevator pitch, but I asked her if we could hold on to our receipt, because it's a Cheesecake Factory. My wife and I would save every Cheesecake Factory receipt, just because it's always been like our place. And I said, I'm kind of a sentimental person. So she just asked, so does that mean you have kids? I said, yes. Asked how many she had. And I asked, where did you deliver? How old are your kids, kind of thing. And then it just sort of led into a conversation about what I do and how I practice. It was a very natural, fluid conversation. But in telling her what I did, this is a woman with 11 kids. She's like, it just sounds perfect. You're telling me that, I can get these, kind of group all my family care in this very affordable package, and it circumvents all the middlemen, and it circumvents these long wait times. But in the practice that I was fortunate enough to join, we see people same day because of the way we're structured, because of our access for patients and our availability. So many things get resolved with a phone call or a telecall that, instead of seeing 30 plus patients a day, even though we're a healthy, thriving practice, we're typically only scheduling 8 to 10 a day for each of us. And so the appointments are longer, but it also enables us to put people on the same day. And to this particular person to whom I spoke, who decided she wants to sign up, that was a huge selling point. One of your 11 kids needs to be seen, or a few of them need to be seen to accommodate that. You've got essentially 24/7 access to a physician, not to a voicemail. And obviously the group dynamic is a little bit different than being a solo, but the principle is still the same. It's improved access for your patient. Overall, you're saving them time, you're saving them money, and you're providing more direct care. And to everyone that I've talked to about so far, talked about this practice to them, that really resonates with them because it's something that they didn't think existed.
Yeah, and so you're actively seeing patients right now, Dr. Dewitt. So I'm just curious, from a professional standpoint, and I want to be kind of careful how I word this, but are your interactions with patients more rewarding than they were before, or about the same, or are you a happier person?
I am, yeah. They are more rewarding. They're more fulfilling. They're more enjoyable because I'm not having to keep an eye on the clock the whole time I'm in the room. I mean, I was a resident when I used to be in our OB clinic or doing prenatal care, whatever. It's, you've got to have a stopwatch in your head almost because you're expected to see so many in a certain amount of time. And those patients often are frustrated as soon as you enter the room because, these clinics are overflowing, but it's all about throughput with these big systems. How many can you cram in a day? And then they wait all this time. Sometimes they wait longer than the length of their actual appointment. They might be sitting in the waiting room for a half an hour so that they can get 10, 15 minutes of your time. And you just got to keep churning them through. And that to me was a very unfulfilling way to practice medicine. Because I knew every single time I left the room that patient had more they wanted to talk about. Now patients, they can talk much more freely about all those things, but I can also tell them on the way out, hey, if you think of something that you didn't think of today, if you are on your drive home, there's something else you want to discuss, send me a message. We'll schedule a telehealth call or call the office, and I'll get back to you pretty quick. And so, yeah, it's absolutely, it's the way that I had hoped practicing medicine would be when I first started in medical school. And unfortunately, it's the way I learned pretty quickly that medicine often isn't in a lot of settings, but it's different this way, and it is better.
Yeah, it's good to hear. And Dr. Williams, so you've been working with Freedom Healthworks for a little over a month or so here. What's your experience like, in the startup aspect of it? Because, there's a lot of people out there taking a wait and see approach, worried to either upset employers or waiting for the perfect time. So kind of a two-part question. What's your experience with our team? And then any advice to somebody out there waiting to pull the trigger for whatever reason?
Okay, so answer one, pretty simple, good. Just kidding. It's been pretty amazing. Like I said, everybody that I've talked to and everybody that has been helping me personally has been the just utmost professional. And y'all have really been kind with the way that information has been passed on to me because, like I said, alluded to before, even the simplest of legal terms or things that we just are not taught is foreign to us. So we're really good at medicine, not really good at law stuff, not really good at, picking out our specific insurances, what we need, what the heck an EIN is, like that kind of stuff. So super helpful with walking us through that. So super grateful for that. And then as far as the wait and see approach, there's probably a lot of paralysis by analysis type of stuff going on. And my personality, as soon as I get, focused on one thing, that's kind of all I can think about. And I know I have to do it. It's just a matter of time of when. So unfortunately, I don't really suffer from that. So I can't really direct anybody who might do that. I'm just kind of a, cannonball into the deep end kind of guy. But if you are stuck on it and you're already thinking about it, odds are Either it's going to be this year, next year, 5 years. Eventually you will go down this path. And I would probably recommend starting it sooner than later, just to save you from the hassle of regret, to be honest, I guess. But super happy, super pleased, super excited to be doing something else. And super grateful that Freedom has been able to guide me the way I know I would not be able to do it by myself, for sure.
Dr. Dewitt, anything you wanted to add on, or any other advice you want to give to people who are thinking about DPC but might not be able to take the leap right now, or ready to take the leap?
Yeah, to piggyback off Dr. Williams a little bit, the paralysis by analysis, I think a lot of physicians are guilty of that. I think many of them are inherently analytical people. I don't think that's necessarily a bad thing, but I think that when it comes to a decision like this, it can be a bad thing. I think that for Chris, you and I have talked about this before, that one of the things that some physicians may not be trained to appreciate, it's not buried in the annals of the anatomy atlases and biochemical lectures, you're not really learning about opportunity cost. And that is something big for people, for prospective clients of this platform, for physicians and free thinkers, that they need to really consider, because as Dr. Williams said, it may be 5 years down the line, you're going to be pretty dissatisfied. Maybe it'll drive you into something like this. But it's better to seize this kind of opportunity and jump into it excited than just have to be driven into it out of dissatisfaction. It's also better to do it earlier, because the more time you afford yourself to build something like this, that's just the more time you're going to spend happy and delivering the kind of care that you want to deliver to your patients. And so we talk all the time, from a preventative care paradigm, that earlier interventions are better. This is exactly that. It's an earlier intervention for your career, for your personal well-being, your family life, work-life balance, your family life, but also for your patients, because you're going to be making bigger differences for people earlier on in their disease courses, potentially helping people ever develop a disease more easily because of the extra time you can spend educating them and counseling them. It's a world of difference. It's totally different than what a lot of physicians are accustomed to.
One last question here. I want to encourage any of our attendees, if you have any questions for Dr. Dewitt or Dr. Williams, please use the Q&A window down at the bottom of your screen here. These guys are obviously willing to answer any questions and help anybody out as much as possible here. So Dr. Dewitt, I'll start with you. What is the one thing, if you can pinpoint it, that you are most excited about growing your practice and continuing to take care of people?
For me, it's the time. It's the time with patients. I mean, it's already paid dividends for me. I've already felt so much better about the care plans that I'm instituting for people, because I know that they're not going to leave my clinic and have to ask most of their medication-related questions to the pharmacist because they ran out of time with me. I know that they truly had all their questions answered before we left the room, and I also know that if they come up with any additional questions, they're going to get to direct those right back to me. And for the physicians who are understandably trepidatious about that, thinking, well, by granting more access to you as the physician, doesn't that compromise your work-life balance? Because it can be a bit of a paradox. You think about it that way, but the truth is, because you get to decide how many patients you hold on your panel, and you get to structure your practice and cut out all the stuff in between, it's not costing me more time out of my personal life. Residency clinic, even though that was just one component of residency, was far more demanding in terms of after-hours work than this is. And that doesn't even mean that you have to sit and chart as you're meeting with your patients every day in this model. You can have a face-to-face conversation, still have time to do your charting, feel complete in terms of the counseling and care you provided, feel fulfilled by the end of your day, and still have plenty of time for family.
Dr. Williams, what is the one thing that excites you about your next few months here?
Just kind of doing doing my own thing. Like I said, everybody's excited that I've talked to. Just super pumped to be able to be the best that I know I can be, and really get involved with my patients' lives. I mean, we went into this wanting the doctor-patient relationship, and this is exactly what you'll be getting. And in effect, you'll be getting patients that are happier as well, because they will have better control over their health and their health knowledge and navigating the system, and they know that they will have a doctor that is on their side no matter what. And just super excited to be able to, I made some good relationships, but I feel like they kind of know that I'm beholden to the system. So once I'm released from that, I think the relationship will get even better when there's pretty much like no hidden agendas or anything like that. So I'm just looking forward to getting even better for my patients, for sure.
Yeah, that's great. Thank you both. We have one question from our attendees right now, and I'll kind of toss this up and get both your takes on it. From a financial standpoint, what are your thoughts on residents starting their own DPC fresh out of residency?
Yeah, so it is a hard decision. I think Dr. Williams touched on that earlier too, and it's completely understandable if someone doesn't want to make that jump initially. I mean, you come out with loads of medical school debt. You're essentially working for minimum wage in residency when you divide the pay by the hours. And it's very tempting, I think, to take one of those big academic or healthcare system carrots that they dangle with the signing bonus and to have your benefits covered. And, but you have to read the fine print. You really do, because these non-competes, these restrictive clauses, I mean, if you end up in a position like Dr. Williams had mentioned, where you're being governed at the micromanagerial level in terms of how you deliver care, and you decide, that that's not for you, you want to do something else, a lot of these contracts, they have these clauses that residents aren't really looking for, because they want that first payday, they want to get to finally be that doctor they're trained to be, and they come out really naive and kind of bright-eyed, bushy-tailed. And then they find out, oh, if I do want to start my own thing, if I don't like how I'm being governed, I have to move 30, 40, 50 miles away to escape this non-compete. And so you have to decide, it's a value decision, and it's a cost benefit. We do risk benefit decisions all the time for our patients. And so you have to think about that in terms of taking that leap. But if you take that leap early, before you allow yourself to develop that fear of moving on, you just sort of train your thinking as an outcoming resident to say, this is the way it should be, and it's the only way to do it. Don't even entertain the possibility of signing up with one of these big systems, these restrictive clauses. Then the decision becomes a little simpler. And there is some risk, but the good news is you have that degree, you have that board certification, or at least that board eligibility. And worst case scenario, if you're not able to build the kind of practice you want, or you decide that you're incurring too much financial risk, you can still sign one of those restrictive non-competes. You can still go after one of those big system contracts. That's still going to be available.
Yeah, Dr. Williams, anything to add on that one?
Oh yeah, Dr. Dewitt nailed that one for sure, and I can totally understand how it would be a harrowing ordeal. I remember being a resident and looking at that contract. Didn't know what to read in a contract anyway. My recommendation would be to really read it, because they will have clauses that say that if you discontinue the contract before the contract's up, you pretty much owe everything back. So don't be fooled into thinking that signing bonus is yours when you sign the piece of paper. There's something in there that's going to say you owe it back. Any type of other bonus you owe back, and the paycheck. And just to say, if you're an employee, the hospital system for the most part is going to try to pay you less than what you are worth, because that is what how else would they make a profit if they were paying, people exactly what they are worth. So just be conscientious of that. If I was to do this straight out of residency, I would probably have Freedom working in the shadows while I was doing as many kind of moonlighting or urgent care opportunities to kind of facilitate that income while we got the party started with the DPC. And while you're at urgent care, you can, talk up your patients and go, hey, this is what I'm starting. So you can get patients through that as well. And like Dr. Dewitt said, yeah, if this thing doesn't work out, you can always fall back. Your worth is what's inside your head. You can do whatever you want to. You're not beholden to an office. So don't let anybody tell you that either. Yeah, I can understand how that would be a difficult decision as well, especially being a resident and pretty much working for pennies for what you're worth. But if you can negotiate your contract to, say what you would rather it say, then have at it. But just be careful with those signing things for sure.
Couple more questions coming in, and this one is specifically Dr. Williams discussing your non-compete clause. The question is, how did you get around it? So give us kind of your experience with your non-compete and what you decided to do with that.
Yeah, so in my clause, it was 20 miles from my current clinic, which is close to the Florida border near Pensacola, and 20 miles from the actual hospital system, which is located in Foley, Alabama. And, yeah, I could have fought it. I could have tried to get out of it. But 20 miles from that location on Google Maps, I've typed it into like a radius type of map. And it kind of intersects right at this little town called Spanish Fort, and Spanish Fort's just blowing up the last 10 years. So I was like, maybe this is a sign that I need to, start there anyway. So I didn't fight it. I didn't want to. And to me, I think it's just, you got to walk through the door that opens for you. So like I said earlier, don't burn any bridges, don't irritate anybody, because odds are I might be having to refer back to the hospital system I'm working at. So personally, I just didn't feel like that was a fight worth getting into. Not saying it's unwinnable, because non-competes for physicians is usually hard to keep up in court, because, how dare a person say you can't help somebody, because that's what our trade is, helping somebody. I don't think a jury would be like, no, they're right. They told you couldn't help somebody. So it's just a fight that I didn't want to get into, and I figured I would rather just go out there anyway. But before you negotiate the contract, yeah, that's probably something that could be negotiated. Just read into it before you sign anything. I know plenty of physicians that, were smarter than I was and actually had that taken out of their contract, and they did fine.
Yeah, and with your personal experience, when 20 miles from two locations, that's a tough one. That's one of the more extreme ones that we've seen, especially in a primary care setting or family medicine setting. Yeah, fortunately, it's like both of the radiuses are like to the east, and my location's like to the northwest. So it kind of worked out where it was away from both of those locations, fortunately. And we do see that a lot, and thrilled that you were able to find Spanish Fort, because what we really see is that a lot of physicians want to get back to more the rural setting, and a lot of rural physicians are very, very successful in this. Obviously, from the Freedom side, we'll help with any type of contracts, looking at them, that type of thing. And then, if physicians do decide to fight it, there's some good ammunition in there, like you mentioned. The continuity of care, you just can't abandon patients, and hospitals look really bad on headlines when they say that they don't want a doctor to be a doctor anymore and care for the thousands of patients that they were taking before here. So I know we're running short on time here. We got a couple more questions that popped up here. If Dr. Dewitt and Dr. Williams, if you guys are okay, staying a little bit past 1 p.m. We'll see if everybody stays around. We'll get all these questions answered.
I have to do that because I work for a DPC practice. So.
There you go. Talk about the time. This question is, it looks like a lot of DPC are family medicine. What are your thoughts on internal medicine doing DPC solo and not treating pediatric population? Before you answer, we do work with several internal medicine physicians who have 18 plus or adult only practices, so they are viable out there. But Dr. Dewitt, Dr. Williams, interested in your thoughts.
Yeah, so I can speak for our practice. It's entirely viable coming out of virtually any specialty, I would think. Our office, we have 2 family medicine providers, an internal medicine provider. My residency was in obstetrics and gynecology. You know, and I'm licensed as a general practitioner with a focus on women's health. But yeah, I mean, that's again one of the nice things about the flexibility you're afforded with starting your own practice. Is you can brand it however you want. You can see whichever patient population you're comfortable seeing. You know, we talk in residency a lot, right? Like, don't do anything that makes you feel unsafe. I mean, you just carry that forward. So, you know, you're taking care of the disease states, the pathology, and the patient populations you're comfortable with. You don't have to operate outside that comfort area. And with us, like, we don't actually have a ton of kids in this practice right now. We could, you know, but my partners, they've been practicing a lot longer than I have. And so a lot of the patients they have are patients who followed them for, you know, a great number of years. And they don't necessarily have young children. You know, but we keep vaccines and things on site through VaxCare, which is one of the Freedom Healthworks, you know, platform partners. So we're able to vaccinate kids that do come through, and we're comfortable. We have providers who are comfortable doing those exams. So, you know, by no means is this limited to just one specialty.
Yeah. Dr. Williams, any thoughts?
Yeah, I totally agree. Internal medicine probably, I mean, would not have big issues, big hurdles, in my opinion. And if anything, once you get settled and maybe you start branching out, maybe get a family nurse practitioner or something to add that extra age bracket. Just a thought, maybe once you get up and going, hire a family medicine doc so you can do your thing. But definitely, I think you would have no problem with internal medicine doing this type of stuff.
One more question here, and this one is more towards practice financing coming out of residency. Both of you touched upon heavy debt loads coming out of medical school and then making minimum wage as a resident and working your tail off there. Any tips in obtaining startup funds with a heavy debt load? And, you know, what's your projected break-even time frame for your individual practices?
Yeah, so for us, and you know, to whomever offered up that question, I think it's a great question. But that's a big part of where Freedom comes in. I mean, you can absolutely go into a financial institution. Some people might have better luck with a smaller institution, not one that just looks at you as a collection of numbers and runs their algorithm and says yes or no, but one that's willing to form more of a longitudinal relationship with you and say, hey, look, this is what I want to do and this is how I want to do it. What kind of funding can I get? But the advantage to using Freedom as an accelerator versus trying to do this on your own is you're saving so much money in operational cost. And Chris, I know you can speak more to this too. You know, Chris has relationships with financial, you know, folks that help fund people in this endeavor. Because you know there are plenty of banks out there that would love to give money to physicians that want to start their own thing. But in the end, you know, my perspective at least, you feel less owned by that bank than you do by a major academic institution or healthcare system that ties you down with a contract. Because as Dr. Williams and I mentioned earlier, if it's not going the way you want, you can get a job virtually anywhere, you know, as a physician who's gone through residency. And there are ways to defer, obviously, your student debt. So that there are things that you can do. You can moonlight, like Dr. Williams mentioned. And there are a lot of different ways to do that. You know, it doesn't have to be urgent care. You can do disability evaluation. You can do wound care. You know, there are plenty of sort of backup revenue funds that you're not exposed to as a resident. I went to a residency where moonlighting, for my program at least, wasn't even permitted. So I didn't even realize what sorts of things you could do with a physician's license until I left residency. But the opportunities are definitely there. In terms of the break even, Chris, feel free to interject if I'm off on the numbers, but I think that Freedom generally projects that if you launch using their platform, you're looking at maybe a year and a half, somewhere between 1 and 2 years before you achieve what's considered to be like a robust sort of a full patient panel. If that's what you desire, which can be anywhere from 400 to 600 patients, depending on how many you want to take on. And from an operational cost standpoint, that balances out very, very quickly. You're breaking even, I would think, well before that, depending in part, and this is another caveat, physicians cannot undersell themselves and they can't be afraid to talk to people about what you do. So you will have better success doing this, using the Freedom platform, if you're out there talking to people, getting your name out there, recruiting patients.
Yeah, I think the break-even number of patients before start taking a paycheck is usually in the 50 to 60 or 70 patient, excuse me, member mark. So very low expenses in a lot of these practices. Dr. Williams, anything to add from a practice financing standpoint?
Yeah, I think what we're looking at is about 60, 80, somewhere in there to break even, keeping the overall cost to a minimum, as in like staff, as in, you know, I'm not going to order, you know, $10,000 pictures to hang on my wall, stuff like that. But to Eric's concern, I'm just reading your question. I wouldn't go out and buy a Tesla right off the bat. That might be a poor choice. But living kind of like a resident would help. I'm not too flashy. I still drive a 06 banged up pickup truck, and will until I get out of student debt for sure. But Freedom Healthworks does provide some different opportunities and different levels of financial stuff going on. I'm sure Chris would be happy to show you that. But as far as looking at the VA clinic or prison or jail, wouldn't recommend going to prison or jail. Just stay out of that if you can. Working there might be a better option, but definitely don't go. That'll definitely dampen the being able to pay back your loans. Yeah, just be careful. Just if you're going to sign a contract while you're working with this, you might have an issue with being able to see insurances, because a lot of DPCs, we avoid that type of stuff. So just kind of read the fine print if you're allowed to practice and not have, you know, contracts with insurances versus other things going on. But yeah, I would definitely look into correctional facilities versus moonlighting versus, you know, grinding it out for sure. But even in a hired situation like I'm in right now, you're just, if you already think the grass is greener, you're gonna feel like you've missed an opportunity. But Eric, definitely, we all have holes we got to dig out of, but there's ways, so don't be afraid.
Yeah. Before we adjourn here, any last words of wisdom or closing remarks?
Well, I wanted to, you know, just take a minute to thank you, Chris, for helping, you know, obviously our practice in the ways that you have. And from a philosophical standpoint, it's always nice to find someone that kind of sees things the way you do. And again, I recognize from a patient perspective, from my wife's perspective, we just needed a lot of care for different things. For my parents, just the evolution of healthcare over time has been unhealthy in a lot of ways in terms of how patients are seen and how they're scheduled. And so this, to me, this is that greener pasture. This is that idyllic sort of setting that, you know, I grew up thinking being a doctor was going to be like this. And I was pretty disappointed when I thought maybe it wasn't going to be. So it can be the way that you want to make it. And there's nothing inherently wrong or evil about joining a big group if this isn't for you. But I just, you know, having seen it from that side and from the patient side, I think it's a lot less rewarding, a lot less fulfilling. You lose a lot of the control, you lose a lot of the joy. And this is the best way I could imagine practicing.
Yeah, I totally agree. And never forget that we are humans too. And if you are feeling bad and feel like you got to take care of yourself as well. And mental health for us is just, I think, being swept under the rug. There's a certain stigma to it, but taking the best care of your patient starts off with taking the best care of you, because God help you if you lose that passion, because that's going to transfer into other lives. So the priority is definitely going to be, you know, doing what you love to do, be happy about it, and that'll transfer into your patients' lives as well. So all good things. And Susan, if there's any other questions, they're welcome to email me, and I'll get back to them as soon as possible. If you could give them my email, that'd be great.
Thank you.
Yeah, feel free to share mine as well. I'd be happy to offer the same thing.
Thank you.
Awesome. Well, thank you so much to both of you. I know we went over a little bit, but thanks for taking the time to sit and chat with everybody, and thank you everybody for attending. Like I said, we'll send out a recording if you wanted to follow up on any questions or anything like that. And then if anybody has any questions for Dr. Williams or Dr. Dewitt, or Susan or myself, please feel free to reach out. But thanks so much for joining us, everybody, and taking time out of your busy day.
Thank you.
Thanks for hosting, Chris. Good luck. Congratulations, Dr.
I appreciate it. Thanks, everybody. See y'all later.
Bye-bye.
Have a good day.
You
Bye.
too.